Recording in progress.
Good evening. We are now at week 10. I also want to remind you about next week's change. Tuesday's classes are going to be recorded. No stress. It'll be open for you so you can kind of like look at it at your convenience. And then our Wednesday classes will be Monday, same time. Okay. Don't worry. I'm going to send you an email so that you can have that reminder. But for those of you that are watching the archive, just make sure that you are watching as well. And then, of course, if you guys need anything throughout the week, you guys just reach out, let me know. Okay. Now, before we get into the content for this evening, I want to take a moment to kind of start with this quote. Always remember that you are braver than you believe, stronger than you seem, and smarter than you think. This week is an important moment in the course, okay? Because next week you are taking that cumulative final exam. And for many of you, that can kind of bring on a mix of emotions, right? Excitement, ready to get it over with, pressure, maybe a little bit of uncertainty, right? But I want you to remember that you spent the last several weeks building knowledge and professional awareness that you probably didn't know you could even study in this way before. You're not the same students you were in week one, okay? In surgical technology, confidence does not come from just memorizing facts. We have to know them, right? But it comes from really understanding why things are done and recognizing how each member of the surgical team contributes to patient safety. Every concept that we've talked about, from sterile technique, instrumentation that has to be sterilized, surgical cases that we kind of tiptoed on a little bit, it all connects to one purpose, and that is patient safety. I want you to pause for just one moment and ask yourself something. If you had to choose just one concept from this course that made the biggest impact on how you think about the operating room, what would it be? You actually might be surprised at how much you've actually absorbed. Now, this week we're going to be focusing on diagnostic and assessment procedures. These procedures are kind of help us when we're in the operating room. They help us determine, okay, what's going on with this patient? Are we going to be reconstructing? Are we just doing a diagnostic? Are we fixing? What intervention may be necessary for our patients on the table? We're going to be diving a lot deeper into these concepts in Module 3. But we know as STs, we're not the ones grabbing the lab report and diagnosing conditions, right? But if we don't understand what these procedures are designed to evaluate, how can we influence the surgical plan and anticipate what our surgeons need? So, we're finishing up the course and kind of doing dual hats, right? We're looking at this information and we're preparing for this cumulative exam. This course has taken us through a lot of foundational material, from just looking at who we are as STs to understanding the importance of fire hazards, the surgical environment, our patient safety. Tonight's goal is to kind of put it all together. And this slide right here is that holistic technologist in action. Okay. Now, we as CSTs, and I say we because you guys are already there, we're just going through the motion. We don't operate in isolated pieces of knowledge. In the operating room, everything connects. Sterility connects to patient safety. Instruments connect to surgical procedures. Anatomy connects to what our surgeons are going to actually do. So when you see phrases like synthesis, safety, application, that's really what we are focusing on this evening. You'll notice the phrase at the bottom, from macro to macro, okay? Connecting the cell to the patient. That means understanding how the smallest concepts that we've discussed, things like microorganisms in micro to tissue response, or even diagnostic information, ultimately affects the decisions that are made for the patient on the table. In other words, every detail matters when it comes to surgical procedures. Okay? Now, I want you to think to yourself, if you had to choose one area from theory one that felt the most challenging to master, what would it be? Take a second, think about it, and kind of keep that in the back of your head, because identifying those areas is going to help how to guide and how to help prepare you for this final exam. Okay? So let's get into it. A lot of students approach studying by trying to kind of like go through, we get all the definitions and we try to cram it into our system, right? We're looking at lists or isolated terms. But in healthcare, as you guys have seen throughout the rest of this couple weeks, especially when it comes to the operating room, memorization alone is just not enough, because it's also about context. When you see a term, a rule, or a concept in your textbook, it's important to still ask why the concept exists. That's what I refer to as the why filter. Okay? If you read something like a policy, a sterile technique guideline, a medical term, ask yourself, how does this protect the patient? Almost every single concept that we've covered in this course connects back to patient safety. The second lens is the filter. As STs, we are part of a team. Every member of our team has designed and defined responsibilities. So when you learn a concept, it's helpful to ask, does this fall within my scope of practice, or does it belong to another member of the surgical team? That awareness helps us to understand both our responsibilities as the CST and our professional boundaries. Can you think of a situation in the operating room where understanding the meaning of a specific term or concept would directly affect what you do next? It could be something related to sterility or communication with your team. Let's say you're scrubbed in and you hear a word like, I can't visualize. And you're looking at your back table and you're trying to see, how can I help my surgeon to be able to visualize what they're doing on the field? Okay. It may be you looking and grabbing a retractor that's a little bit deeper to be able to fit, so that now, once they replace the retractor that may be there, now they have that visualization. It could be that you're looking at the field and you may need to adjust the light. You have light handles that are sterile that you can adjust the light for that surgeon again. So now what the surgeon's working with, they have more light. It's more illuminated. They can see better. Okay. Now we're going to continue to go through, but I encourage you to really dive into the material, especially as we get closer to that final exam. All right. Let's begin with foundation of our profession. Okay. Your professional identity as an ST. Technical skills important. We're going to teach you that. We're going to teach you how to pass the instruments the correct way, how to load a knife handle, how to load a suture on a needle, both left-handed and right-handed for your surgeons. But professionalism and understanding our role within surgical, like the surgical team, is just as equally as important. One of the first ideas here is scope of practice. Now, this refers to the tasks that you are legally permitted and professionally trained to perform within your role. It's important to understand the technical ability and legal permission are not always the same thing. You may know how to do something from a technical perspective, but that does not necessarily mean it falls within your legal scope as an ST. I'm going to use myself for an example. As a Navy ST, my scope of practice is different. I've sutured, I've drilled, I've cut, I've done a lot more of a first assist in the Navy. Whereas when I got out in the civilian sector, I was more of the tech. I was not allowed, not necessarily allowed, but it wasn't in my scope of practice to suture. Here's the caveat. It also depends on where you're at. As a civilian tech at the children's hospital, my scope of practice was that, like, you don't touch anything outside of the body. But at some point, I was working with Navy docs, and that rapport was still there. Still had to be careful with my scope of practice, but there were things that they expected as a former Navy surgical tech that they're used to that I was able to do. Okay. So you also have to just be careful with, the facility and making sure you're still within your scope of practice. Now, that distinction protects both us as the CST as well as the patient. Now, you'll also notice the reference to CAHEP and ABHES pathways. Now, these organizations establish the standards for what we do, the educational progress and programs, like what you're in right now. These organizations establish standards for our education. They ensure that each one of you guys receive the training that really prepares you to be able to practice safely in the operating room. Now, this is part of the larger framework that helps maintain professional accountability, and it's really important to kind of grasp, because you will see concepts, knock on wood, you'll see concepts on that cumulative exam asking certain questions about who allows for what, when, where, and how. Okay. Now, the phrase ego primo. I have seen this on CST exams. I have seen this sometimes pop up on cumulative exams. The patient first. This principle should guide every single decision you make in the surgical environment. When uncertainty kind of arises, the question becomes, what action best protects the patient? Okay. One concept that I have seen students sometimes kind of like overlook is the difference between legal capacity and incapacity. This idea connects back to like patient consent, decision-making authority, ethical responsibilities in healthcare. These distinctions actually influence how procedures are authorized and how care can be delivered. Now, I'd like you to think about the scenario at the bottom of the slide. A surgeon asks you to perform a task that falls outside of your scope during a crisis situation. What responsibility do you have as part of the surgical team? I want you to consider how professional judgment and patient safety intersect in that situation. Now, as we continue to go through tonight's live session, I want you to keep the idea of professional responsibility in mind. Your technical knowledge matters, but so does your awareness of your role within the surgical team. That awareness is a part of what defines a competent ST. So let's spend a moment looking at some legal concepts that really influence how care is delivered in the OR. In healthcare, every action taken is tied to something called the standard of care. The standard of care refers to the level of practice that a reasonably competent healthcare professional would provide in the same situation. It is essentially the benchmark that helps determine whether care was appropriate. Now, we look at one doctrine that you may encounter, you may see questions, especially this week, on res ispa locator, which roughly translates to the thing speaks for itself. This concept applies in situations where outcomes clearly suggest that something went wrong during care. For example, a surgical sponge left inside a patient. The situation itself suggests that the standard of care was not followed. You'll also notice the reference of informed consent. You'll hear that a lot. Informed consent ensures that the patient understands the procedure. They understand the risks and potential alternatives before agreeing to be treated. It's important to remember the difference or the different members of the surgical team and how each has a different role in the process. The chapter also discusses HIPAA that you kind of see right here, which of course we're trying to protect patients' privacy, right? Now, the protection extends beyond written records. I have seen concepts asked about this. It applies to conversations, electronic information, how patient information is shared within healthcare environments. Sidebar. That's why I have such a problem with Grey's Anatomy and other medical shows, because they are talking about patients' information all over the place. Okay. Now, a concept that I've noticed that students kind of confuse when it comes to this chapter is unintentional torts and negligence. Now, these legal ideas really do help determine whether harm occurred due, make sure I get it right for you guys, due to failure to meet the expected standard of care. Now, you have to understand these two distinctions because it helps us recognize the legal responsibilities associated with patient care. Let's look at this bottom scenario here. Surgical count. So, if the surgical count itself was incorrect at the end of a procedure, what responsibility does the surgical team have to address that situation before the patient leaves the operating room? What do you think we should be doing? Counts messed up? It's wrong. Maybe we're missing a sponge. Maybe we're missing a needle. Maybe it was a big belly case and we're missing an entire instrument. What is one of the first things? And granted, I know we're going to be talking about this a lot more in module 3, but right off the top of your head, the count is wrong. What is your first instinct to do? That's correct. We're going to do a recount. We are going to count us on the field, and I'm going to show you guys how to do that before you guys get into the lab. Our circulator is going through trash cans. Yes, their gloves on, they're searching. We have mag rollers if it's a needle. If it's an instrument, we are communicating, hey doc, just so you know, the count is off. You're gonna keep counting. But at some point, if that sponge, that needle, or that instrument is not found, we're gonna request an x-ray so that everything that we could have done for our patient is done. Okay? You're going to learn this. It's going to be muscle memory. When you're doing your counts, you're going to automatically, a lot of times we'll be counting before we even do the count just to make sure I know where my sponges are, I know my needles are, I got one working, and you're going with the flow. Now, keep in mind that legal principles in healthcare are not just abstract ideas. They exist to protect patients and to guide how healthcare professionals practice safely and responsibly. I know I stopped at responsible. All right. So let's get into the second pillar, communication as a safety tool. In the OR, communication is not casual conversation. It's really that safety tool. Go back to that sponge that was missing or that needle or that instrument. Every instruction, confirmation, and response helps to ensure that the surgical team is working together effectively to protect the patient. You're going to hear me a lot in Module 3 say, trust but verify. Trust but verify. And that's going to be with labeling, with medication, with anything that you allow onto your field. You're trusting the circulator, but you're also verifying. That's communication. Okay? Now, one type of communication we use in healthcare is that therapeutic communication. This type of communication is purposeful. It's focused on patient care and on completing specific tasks. It's clear, it's concise, and directly related to what's going on with our procedure. You'll also notice the chapter talks about social communication. In most environments, casual conversations is normal. But in the OR, especially during critical moments like induction, or like induction meaning we're getting ready to intubate the patient, or key parts of the procedure, unnecessary conversation can actually become a distraction. So we, as the surgical team, we maintain our focus, especially on the patient and on our surgical field. One of the key strategies used in healthcare, again, is that closed loop communication. The process involves giving a command, repeating the instruction back, and confirming that the correct action has been completed. For example, when you guys first get into the operating room and you've learned how to gown and glove, you set up your table, you fix your Mayo stand, you bring it up to the sterile field after drapes have been gone. Timeout has already been done. Surgeon's going to say knife. And a lot of students will grab the knife and repeat the knife back. So it's knife, knife. Not that the surgeon doesn't trust you, right? But as you're learning who that surgeon is, your first instinct is just to make sure you're repeating exactly what they've asked for, especially when it comes to giving them local. One of the first things before the knife is even handed up is usually some type of anesthetic. Yes, the patient is under general, but in some cases, we still give a local anesthetic to prolong the effect after the patient has waken up. So if I'm giving the surgeon 1/4% Marcaine with epi, and I've repeated it, I'm going to also let them know 1/4% Marcaine with epi. I'm not going to just say, here's your anesthesia or, syringe. It's going to be 1/4% Marcaine with epi. So we're still having that communication. Okay. This really does help reduce misunderstandings and ensure that everyone on the team shares the same information. Does that make sense? Okay. Because you're going to practice it a lot in the lab. Now, the third pillar. Now we're looking at critical priority. This is the biological foundation behind surgical care. Everything we do in the operating room ultimately affects living cells and tissues. So understanding that basic biology helps us to understand why certain clinical decisions are made. You'll notice on the left side, you'll see a mitochondria, right? Which are often described as the power plants of cells. They generate the energy that cells need to function, repair themselves, and even support healing. When tissue is injured during surgery, because remember, we are causing trauma to tissue, we're taking a knife and we're cutting it, right? The body relies on cellular energy to begin repair. So even something that seems very small, like a function of mitochondria, it connects directly to post-operative healing. Thus, we learn microbiology. Now, on the right side, we see the nucleus, okay, which acts as the center of the cell. The nucleus contains, you guys remember, the DNA, which directs how cells grow, how they divide, how they actually repair themselves. The genetic information influences how tissues respond to like injury, infection, and with us intervening surgically. We also look at osmosis and osmotic pressure, which is something that I've noticed on the final that sometimes gets overlooked. Now, in clinical practice, this affects decision related to like IV fluids and tissue hydration. Understanding these mechanisms helps explain why specific solutions are used in patient care, which we talk about in pharmacology. Now, one of the questions that tends to get asked a lot is why is isotonic saline commonly used in patient care, and what might happen to cells if they were exposed to plain water instead? This isn't to answer, but to kind of like let you see how the thinking is, especially when we get into pharmacology. Remember that you consider how fluid balances at the cellular level could affect tissue integrity. And we literally break this down in module 3, okay? But these are some of the concepts that are being pulled from module 1 to module 2 and carried on into Module 3. Now, keep in mind that many surgical decisions are grounded in these biological principles. Understanding what happens at the cellular level helps us to really understand what happens to the patient as a whole. And it also helps with our anticipation, because if we know what type of injury or what the patient has going on, then we can already kind of anticipate what type of fluids we may actually need on our back table, or we'll hear our circulator and anesthesia hanging for our patients intraoperatively. Now, physics and energy. Energy devices are constantly being used during surgical procedures, and understanding how they work helps us as a surgical team use them safely and effectively. You'll see here an example of an electrical surgical unit, okay, or a circuit. You'll hear us say Bovie pencil a lot. Now, one thing I do want you guys to know, that this Bovie tip is a sharp. It'll make more sense when we get into Module 3, but just keep in mind that this tip is removable and it is a sharp, okay? Now, in a monopolar electrical surgical system, energy begins at the generator and travels through the active electrode, okay? So this is your active electrode. It then passes through the patient's tissue, returning to the generator through the return electrode. So you have your return electrode. Now, the circuit allows the surgeon to cut tissue or actively achieve hemostasis using controlled electrical energy. Understanding the flow of energy helps to ensure that that system is functioning safely. Now, the chapter also talks about laser technology. Yes, we use lasers in the operating room. Now, different lasers operate at different wavelengths, and those wavelengths determine how the laser interacts with tissue. For example, some lasers are designed to target pigment or tissue characteristics. This is why types of lasers being used affect both the surgical technique and safety precautions required. One detail that I have seen been overlooked involves laser safety measures, hint, hint, including proper media selection and eye protection. In the operating room, we have certain eye protection for certain lasers, and we place the appropriate tag on any entrance of the operating room with goggles for that appropriate laser taped to it. Every single individual, including the patient, has laser eye protection for the particular laser that's being used. So just keep that in mind. Now, all of the precautions that you're reading on this week are important because laser energy can cause injury if appropriate safeguards are not in place. And that's why it's so important for us to recognize those measures. And it is part of really maintaining a controlled surgical environment. Okay, so here's a question I want you to be thinking about. If an electrical surgical unit alarm were to kind of just be beep, beep during a procedure, right? What would be the first thing you would want to check to make sure the system is functioning correctly? Would it be the machine itself? Would it be the cord? Would it be the generator? Now, keep in mind, we check before the patient's even in the room. So I want you to think of setup. So you're not sterile yet. So just think of, you're just going through the room, you're checking, you turn on the machine, and an alarm starts, and it's not really working properly. Okay? I want you to think about how equipment safety connects to patient safety in a situation. And I say that because you may see concepts where here's a scenario. What's the most important thing? What are you checking? What are you looking for? Okay. Now, environmental hazards in the operating room. The OR is a highly controlled environment, but it also contains several potential risks. Now, understanding those risks help us as CSTs prevent accidents and maintain patient safety. One important concept to remember is that fire triangle. We have heat, fuel, oxygen. In the operating room, these elements can easily be present at the same time. Heat can come from energy devices such as electrical surgical units or lasers. Fuel may come from drapes, prep solutions, other materials. Oxygen may be present because the patient is receiving supplemental oxygen. Okay. Now, we often help manage elements of the environment, especially materials like drapes and prep solutions. So we have to just be aware of material, how it interacts. For example, let's say we are doing a total knee arthroscopy. So we're taking a scope through the knee and the surgeon asks for a sucker shaver. And they're going to kind of remove some of the meniscus because it's not enough to take it all the way out, but they just want to smooth it out a little bit. Now, the one thing about the sucker shaver is that it has blades on it. Okay, and one end it's smooth, the other side it has like little blades. And let's say that sucker shaver is just sitting on your Mayo stand with the drape and it's foot controlled. Now that's that's important to hear later, okay? But just keep that in your mind. So you're going through your thing, the OR is already loud, the suction is the loudest thing in the room, and you notice some sparks happening. You look over and the sucker shaver has been rubbing on just the drapes of the Mayo stand, and that friction is potentially causing a fire, right? So everyone's checking their feet because the paddle is usually by the surgeon, but sometimes a resident may be near and they may not even notice, or we may not even notice. So we just have to be aware of our surroundings, where everything is, so that the patient safety is not at risk. Okay. When imagining equipment that is being used in surgery, we follow a couple of principles. We try to limit exposure. So this is why we try to open up the room as close to cut time as possible. So a lot of times, especially in, I'll say ENT, cut time is usually 7:30. A lot of times we may not even open up our room till 7:15, 7:20. And it's not because we're procrastinating or anything. It's just because those cases, the instruments that are small and the cases are really fast, and we try to open up as close as possible. But here's the caveat. Let's say we have a spinal scoliosis case. Okay. We're going to probably go into our room, maybe even 6:45, because the amount of instruments and the setup is going to take longer. Cut time is still 7:30, but the instrument load is also going to determine how we navigate in the operating room. Distance is another one. We increase the distance from our source. And then we use protective barriers. So we have our drapes, we have our pill packs. We're gowned and gloved. If you've ever seen total knee arthroplasty cases, doesn't matter if it's hip, shoulder, knees, and we wear those space suits, that's that protective barrier. Okay. Then we look at facilities and agencies. Okay. Keep in mind that this is where we talk about the unrestricted area, the restricted area, and semi-restricted area. The operating room itself is semi-restricted until we're getting ready to open, and then it becomes restricted. That's one of the biggest things I want to kind of hit on. So like, let's say you see a concept that's mentioning the operating room is always a restricted area. Keyword, always. The operating room itself is not always a restricted area because in some points it's semi-restricted when we're not open and sterile. Does that make sense? Okay, because I have seen that concept. Okay, so I just wanted to kind of touch on it. Disaster preparedness, and don't worry, I just want to kind of go over some misconceptions so that when you are studying for next week, you really do feel confident going into that final exam. Okay, now keep in mind, immediate, delayed, minor, expectant. Mass casualty events occur when the need of a patient exceeds the available resources of the healthcare system. Um, Make sure you're reading up on FEMA, Department of Homeland Security. All of these support communication and logistics and resource distribution during large scale emergencies. Now, we talk about the patient experience. Up until this point, we were looking at legal responsibilities, communication, biology, physics, reminders of environmental safety, and disaster preparedness. But all of these elements ultimately exist for one reason: the patient. At the base of the pyramid, you guys remember you have your psychological needs, breathing, hydration, physical stability. Above is safety, and we get all the way up to self actualization. As STs, we have to understand the patient's experience because that's going to help us ensure that we provide support not only for the procedure itself, but for the person undergoing it. Now for what we've been ready for. We get into diagnostics and pathology. This is really big for us in the operating room. During many surgical procedures, tissue samples are collected so that specialties or specialists or pathologists can examine, determine what's happening at the cellular level. These diagnostic findings often guide what the surgeon's going to do during the actual procedure, especially on staging cases or oncology cases. So when we're doing a staging case, we're taking multiple specimens and we're sending it off with a runner. Pathologist is waiting, standing by, and we're kind of waiting for them to tell us you got enough margins, take some more. I need you to just make sure that you have everything, or you guys are good to close. Okay. You'll notice several types of biopsies. You have a needle biopsy, typically involves removing just a small tissue sample using a needle. An excisional biopsy involves handing the surgeon a knife with some pickups, and they're going to remove an entire lesion or suspicious area. A brush biopsy is where they collect cells from surface or tissue. Each of these approaches helps provide information about the condition of the tissue that's being examined. Now, one important diagnostic method used in the surgery is the frozen section. And you're probably like, wait a minute, how do they freeze the specimen on the back table? Okay. Now, we're not freezing. We don't have like sterile ice on the back table. The sample is quickly sent to pathology so it can be examined immediately. The pathologist can provide rapid feedback to us, which will really influence how the procedure continues. You'll notice the reminder here: no formalin is used for frozen sections. I repeat because I have seen that concept missed. No formalin is used for frozen sections. That's because the tissue has to remain unfixed, like in its regular form, so it can be processed rapidly, as opposed to permanent formalin or permanent sections, where now we take the specimen in formalin for long-term preservation. This allows the pathology team to kind of perform more detailed analysis after the procedure. So 9 times out of 10, this is coming during the procedure. This is going to be sent usually after. Okay, that's not the end all be all, but that usually kind of follows the path. With permanent, the process takes longer but provides more comprehensive diagnostic information. Now, another detail that sometimes overlooked is proper handling of frozen section specimens. Now, because the results may guide the surgeon's immediate decision, Careful communication and correct specimen handling are extremely important. Now, why might it be important for the surgical team to clearly distinguish between a frozen section and a permanent section during a procedure? And as you're thinking about this, I want you to think, how might that difference affect what our surgeon is going to do next? Consider how diagnostic information influence what's going to happen for our surgeon or surgical planning for our patient. Okay, that is very important. So they get the specimen and they got to take it to the lab. Of course, these tools provide information that helps the team, helps us to understand what's going on with our patient's condition before and sometimes during a procedure. You'll see several imaging techniques listed here. We use fluoroscopy. Often we use the C-arm in the operating room. Let's say we're doing an open reduction internal fixation. C-arm's coming in, okay? It provides real-time x-ray imaging during our procedures. Now, as our orthopod is fixing the bone, he or she can actually visualize. They can see vessels. We can look at implanted devices while the procedure is taking place. Other imaging methods include MRI, CT scans, which provide detailed views of internal structures, and it does help guide diagnosis and treatment planning. We also talk about contrast media. Now, some substances are used to improve the visibility of certain structures during imaging. Radiopaque contrast can block x-rays, allowing now for specific areas of the body to appear more clearly on imaging studies. It's also important for us to check allergies, particularly iodine-related allergies, when contrast agents are being used. You'll see a laboratory test here, CBC, PT, PTT, which relate to blood composition and coagulation. These tests are going to be important because now we can evaluate factors like bleeding risks and overall patient stability before surgery has even begun. Another concept that sometimes gets a little bit confused is the difference between tumor staging and tumor grading. I mentioned staging just slightly earlier. Staging refers to how far a cancer has spread within the body. So when we're doing staging cases, we're taking specimens and seeing how the margin, if the margin has stopped, or if we need to continue to take more tissue to provide to pathology. Grading refers to how abnormal the cancer cells appear under microscope. So one is intraoperatively, and one is once the specimen has been removed from the patient and now under a microscope being examined. It's really important to make sure that you can differentiate between staging and grading. Recognizing that distinction is going to really help clarify, especially for our physicians, the disease progression. Now, we have a scenario, okay? In clinical practice, problems rarely appear in like neat little categories. Instead, you have multiple factors that often interact, unfortunately, at the same time. This exercise is going to really help us think through a situation the way you're going to be with your surgical team. Okay. So imagine the situation. A geriatric patient is undergoing a laparoscopic colectomy, and the surgeon is using a laser during the procedure. During the case, fire spark due to an oxygen leak. Immediately, several issues are occurring at the same time. Now, when situations like this occur, it can be helpful to kind of like mentally organize them or organize the problem. For example, we may ask ourselves, what biological factors are affecting our patient? What environmental hazards contributed to the fire risk? Are there legal responsibilities or documentation concerns? And was there communication breakdown within the surgical team? This type of like structured thinking helps us as a team respond more effectively during complex events. You'll notice the slide also highlights a communication breakdown as a high missed issue. In many clinical incidents, the root cause is not a single technical error, but rather a failure in communication between members of our surgical team or healthcare team. This is why clear communication is one of the most important tools we have for maintaining patient safety. I'd like you to think about this scenario, okay? And put yourself as you're part of the surgical team. You notice a sign of fire risk, it's starting to develop. I want you to be thinking about what actions or communication steps might you take just to help protect your patient. I know you haven't been in the lab yet, but at this level, seeing remembering the setup and where you would be standing, I just want you to be thinking about it. Think about how the different pillars that we discussed today might guide your response, because before you know it, you're going to be in the lab, and even before then, you're going to be with real patients. The other thing I want to kind of remind you is that this kind of scenario reminds us that we require more than just technical knowledge. I've mentioned before, we wear a lot of hats in the operating room. It requires the ability to connect multiple pieces of information quickly in order to support safe patient care. Okay. Now, before we get out of here, I do want to give everyone an opportunity to complete the survey. Let me paste it here. For those of you that are watching the archive and for those of you that are here, you guys have spent the last several weeks working through a lot of material in this course. Some may even have learned a different way on studying and thinking about different questions. Your feedback actually helps us to kind of understand what supported your learning and where improvements can actually be made. I am from a mindset that closed mouths can't get fed. I can't help you if I don't know what's broke. So I really, really, really want to hear what's working, what could be changed, what you liked, and be as honest as you possibly can. Okay. You have 5 minutes. Your responses will help us to kind of evaluate the course material, discussions, and really kind of actively support what you need. And for future students that will be taking these courses and what you may need going forward into module 3 and onward. So I am going to be back once the timer is done.
Does anybody know if this is the same survey that it's like a 1 through 10 scale? I think I already filled this one out.
You mean for the ABHAS? This one's
Yeah.
different. This one's for the course itself. This one is more for like, so you'll have I think you guys have 3 classes, right? Math, 300, 200, and 210. So you'll have a survey for each one of these, specifically for what you liked for each particular, each particular course itself. The ABHAS was one slightly different.
I have not filled the app has one because I haven't received the email or link to that. Dr. Shrum just notified us that we would receive something like
Oh,
that.
okay. So you're
Sorry,
okay.
not Shrum, to Chantel Haskins, someone like that.
I think so. I
Pretty
think
sure.
I know. Yeah, I think I know. Yeah, yeah.
So
The
if
one,
this is that's
this
at
one's
the end
different.
of the week,
Yeah, this one should be
yeah,
different unless you've already done one for each of your classes already.
yeah, it was under the week 10 at the very bottom.
Yes, yes.
Yeah, I did
Then,
that.
okay, then enjoy your 2 minute 55 2 minute break.
All right, thank you.
You're welcome. All right. For those of you that are watching the archive, I have some questions that we're going to discuss in the forum. Why is early detection through cancer screening important, and how can it impact treatment outcomes? How do diagnostic tools like biopsies and imaging techniques contribute to really figuring out the best treatment plan for cancer patients? And what are the main differences between benign and malignant tumors? Quote of the week: always remember that you are braver than you believe, stronger than you seem, and smarter than you think. Of course, from Christopher Robin. What questions do you have for me? All right, now we are coming up on the final hours. So if something does come up, y'all, please let me know. Your week 9 quiz feedback is already up. I worked on that today, so that is up. Or no, yesterday I think, as well as the kind of like group um highly missed concepts. So use those, go back through your notes, look at listen to your videos, your audio, try to use as many resources as you can and work in small batches as you prepare for your final exam. Okay. Um, with that, please have a wonderful rest of your evening. And I look forward to seeing everyone who can attend tomorrow's live session. Good night, everybody.